my good friend Sargon Lazarof. I am the what's hot and what's getting hotter guy. I write the column. How many of you read that column in HD Impact pretty much every month? You're getting to see it live. You are the first group to ever hear about this revolutionary new way to provide your patients with the ability to eat, speak, and chew if they have a tooth that has to come out. Right, Sargon?
That's it, absolutely. It's called the Ultra Tooth. We're going to introduce the Ultra Tooth to you, and the wonderful thing and the great news about this thing. By the way, thank you for invitation and being here. If you get a chance. The great news for your practices is that for the first time, you'll be able to tell that patient that is coming into your office, sad, emotional, about losing a tooth. You'll be able to tell that patient, don't worry, I'll give you a brand new tooth and you can walk out and start chewing, eating with this. And this has been done in my practice for 27 years, as a 27-year clinical research history behind it, and we are introducing it to you today.
So let's take a look at this. First of all, how many of you here place implants in your practice? Okay, great, good service. But can your implant, and when your patient leaves, can they pass the Apple test? That's what we're talking about. You know, Steve this morning talked about unleashing our creativity. And nobody has become more creative than Sargon in giving us something that we can give to our patients. When I evaluate new products, materials, and techniques, I want to look at things that are faster, easier, and better for me, the doctor, but who is the ultimate end user? It's the patient. So it's got to be better for the patient. And you want to talk about something to put on Facebook? This is what you're going to put on Facebook. So let's talk about having your implant pass the Ultra Tooth's Apple test, because let me tell you, you've heard about immediate load, but this is the first ever FDA approved implant for full functional load. And this has been around since '94. Why are you hearing it now? Because it's finally been perfected, and it's the genius and creativity of Sargon that has been able to do this for us. So let's move forward as we do this. Tell me about this implant, Sargon.
This implant, what's different about this implant and regular screw-type implants that you've been used to, we were told that we place an implant and we have to limit the micromobility, the motion, the movement to this. And Brandemark said, bury it, don't touch it for 4 to 6 months. And later on, you know, we learned to maybe take it out above the tissue, single staging, and some companies started talking, after they heard about this, started talking about immediate provisionalization. Basically, put a screw in if you have perfect bone, if you have 40 newtons of torque on it, and if the patient doesn't bite and chew on it, he can walk out. But that basically became a gimmick. In most practices, it didn't work. And what happens was a bait and switch. The doctors that were offering it, they would get the patient in, the patient says, can I have a tooth? Say, well, yeah, you can, I can place it, but you can't buy it, you can't eat. It's just like, I'll give you a car, I'll give you a Ferrari, but no engine, you can't drive it. So this became basically a bait and switch where the doctor would say, but if you bite on that tooth, it'll fail. So why not use a more proven technique? Now, about 30 years ago, when I was introduced to this technique, I said, why are we waiting for bone to come to the metal? Why not expand the implant and have the metal go to the bone and contact the bone? So I went into this new area of having expandable screws. So what I had to prove is how an expandable screw design would work and would function, if it's strong enough and it would take the test of time, and how the bone would react to it. And the great news about it is that after the studies that were done in Indiana University, in France, in Japan, and Korea, will show you that in addition to being immediate full function, by the way, as Dr. Glazer said, this is the only implant that is FDA approved for full functional immediate load, and it has its own category for that. So besides having that, it has many more improvements, and they'll be talked about right now. which are basically the 5 features.
So we're going to talk about those features because that's what makes this revolutionary new implant really sort of correct the mistakes that we've seen in the past. So let's look at what really makes UltraDent different, and it's 5 key benefits. Let's go over them. First one, comment on it.
Well, we talked about the full functional immediate load, okay? So by putting a tooth immediately in the socket, remember this, next time you do an extraction, what happens to that tooth when you extract it? You basically, I call it soft and hard tissue mutilation. We're taking the tooth out and allowing the papilla and the gum and the bone to collapse. Then the patient has to go to a specialist to recreate all that gum and bone when it comes in aesthetic situations. Or that's just too difficult for the general practitioner. So it becomes a specialty and the patient has to spend money for bone grafting, soft tissue grafting, and then implant placement. And if everything goes well and everything is perfect, we bring back what was there before that we destroyed by extraction. So second best thing about this thing is that we are preserving that gum and bone contour that is always going to be there and we're going to maintain it. Now, the third point, for the first time, we have an implant that is not a cylindrical implant. It's wider at the apex. And we'll show you how an Eiffel Tower is much more stable than a cylinder. We've been fighting for years, and all the companies admit that they get 0.2 millimeters of bone loss per year. Now, sometimes it's that, sometimes it's more. What does that mean? Think about it. You have a patient that comes in her 20s, gummy smile, you do implants on her. For those of you who practice long enough, you've seen the case come back 10, 15 years later, patient smiling, with the neck of the implant showing through the tissue, or actually the neck of the implant showing. So by design, we're putting something in an aesthetic zone that every company has admitted that has a flaw. And the flaw is constant bone loss. And if you have constant bone loss, what does that mean? Shouldn't be used in aesthetic areas. So the best thing about this is the UltraTooth is Eiffel Tower. It transmits forces instead of around the coronal bone apically. And bone never changes around it. That means besides being able to preserve the emergence profile, we can maintain it long term. So we'll show you cases that are 15, 20, 25 years that they look exactly as the time we put them, with an added advantage of better bone quality. Now, something surprising happened when University of Indiana did this study, and they said, you know, we're getting this area of pressure. So obviously, when the implant expands, UltraTooth expands, it's putting the surrounding bone and tissue under pressure. So in doing the histological slides, they looked at an area that was improving in bone quality. They called it an oscillation effect, meaning that the surrounding area, because being under pressure exerted, translated into a positive force of maintaining and improving bone and gum. We'll show you clinically what that means.
So you know, as dentists, you and I, we're visual and tactile, right?
Yes.
So if you show it to me, we can understand it better. And if you put it in my hands, we definitely know it. So I mean, and we, by the way, the booth in the exhibit hall is great because you actually have the kit, you have the implants, they can touch and feel, ask you the questions, or you know, whatever. Let's go over. We have case examples to show these 5 points.
But we have one more point that I want to cover. The last point I didn't cover. Obviously, this thing being wider as it expands, it also integrates inside and outside, increased surface area. In other words, a 10 millimeter UltraTooth has a surface of a 13 millimeter screw.
Which is cool. We're going to show a slide of that because that really impressed me when I saw that.
All right.
So, first point, immediate full functional load. This is a 40-month study, prospective study, 275 implant study, 96% success in the mandible, and 100% success in the maxilla. This is 7 years post-op we're looking at here.
Yes, and I want you to pay attention. These are teeth number 8 and 9. For those of you who know implantology, what do they tell you when you want to place implants in 8 and 9? Never put two implants next to each other because you lose a papilla. You get a black triangle. We'll show you 25-year cases that have not changed. So radiographically, you can see the big thing about this thing is, besides being immediately loaded in full function, patient biting an apple right after the surgery, it's that bone between the two implants. That bone you'll never see on any other implants. And that's the bone that maintains that papilla for a long time.
So as we see in the next thing, we're maintaining emergence profile. Now, if you've been in practice for any amount of time, you've had patients who have had implants placed, and all of a sudden you see the collar sort of receding, the tissue's going back. You're losing the concept of a natural looking tooth coming out of and emerging from the gum.
This is an example of that. This is a patient that came in and was complaining because a few years before they had this implant, it looked fine. But now the implant was starting to show through the gum. And guess what? In a few months, what's going to happen is full recession and that implant is going to get exposed. What are you going to do about this case? What does the industry do about this case? Do they talk about it?
No, they hide their head in the sand on it. So we have here, we're going to maintain that emergence profile. You mentioned before when we were covering the beginning of the points is how many of our patients spend an inordinate amount of time and dollars to go back to the periodontist to help them recapture the papilla and to move the tissue down, and especially in the front, get rid of the black triangles. This happens to be an interesting case because you had done this case and 7 years later had a chance to take a look without the crowns what was going on underneath.
Yeah, we did a study on 50 implants with immediate crowns. We have this new material that we were testing to make immediate crowns at the time of surgery. It worked great for 6-7 years and it started fracturing. So we had an opportunity to look at many implants with broken crowns that we could actually take off and see what was happening around the implant. And this is one of the cases. I want you to pay attention here. When the crowns came off, we were taking the impression for new crowns to be placed. Look at the emergence profile. Look at the papilla in between. This is 7 years later. Ladies and gentlemen, this is not possible to do with any other implant. It's only UltraTooth that can give you this kind of result.
And do it the same day you take the tooth out.
Exactly.
I think that's absolutely incredible. Point number 3 you made is about we do not lose any coronal bone because of this expanding pod or the upside down Eiffel Tower effect.
This is point number 3 is the bone compaction. Here in the photoelastic medium, if you look at the top 2 pictures, one on the left side is a screw, and on the bottom side is the expandable implant. You see the circular zones that we have, that's the effect of this on the surrounding bone. Now, when the lateral force is placed on it, it's the bottom 2 pictures, you can see that zone on the screw, the left-hand side, is towards the top of the implant and the coronal region, and the expandable implant transmits it all apically.
So what we're seeing here is they're actually putting a load at an angle on the implant to move it laterally,
Exactly.
or try to move it laterally.
Exactly. This is a study that was done in UCLA where they put pressure, a lateral load on it, and it's the only device that shows this result, where all the forces are transmitted apically, and it's understandable. What's the difference between Eiffel Tower and the Tower of Pisa as far as stability? Okay.
There's no mobility. This is telling me there's no mobility down the line.
Exactly, exactly. And the pressure is transmitted apically away from the coronal region. And what does that result in? Maintaining that bone and papilla in the coronal region.
Okay. And here we see that the stability of the implant was greater than that of the expanding implant.
Yes. This is not finite element analysis that was done that actually confirmed these results that we're talking about.
So we've got distribution of the stress, long-term result. What about surrounding teeth that may show some mobility?
This is precisely one of these points. The next point is going to show, when we talk about that oscillation effect, the bone surrounding area. This is a case that we're showing that this 12-year case, because of the Eiffel Tower design, because it's the only device that is wider at the apex, it preserves the bone in the coronal region. For those of you who are familiar with implant, you know osseointegration always starts with the first thread and starts going down the implant length. Look at this case. 12 years later, the bone has grown on the collar and actually gone beyond to the abutment. So this does not exist in today's implantology with current devices. It's the only ultra-tooth that will give you such results, which maintain that surrounding tissue.
It seems to me that if I look at 12-year cases with my patients, that I don't see this that you're seeing on the right side of the screen, but rather I'm seeing the first 3 threads exposed.
Exactly. Yeah, exactly the opposite occurs.
So bone is growing higher, therefore greater stability?
Absolutely, yes.
Fabulous. That's a service to our patients. So, surrounding bone density.
This is incredible. This is a side effect that we were seeing. When we were treating teeth with the ultra-tooth, I was noticing in my practice, and I was getting a lot of calls by doctors that were using the system. They would call and say, you know what, I had tooth number 8 that I removed and I placed an ultra-tooth. Number 7 had some bone loss, had some mobility. But after I placed the ultra-tooth, it has stabilized and everything looks better. And this was happening clinically, and University of Indiana explained that is that oscillating effect that we were talking about. You can see that circular region, that surrounded bone that is affected on this device. You can see it in histological slide on your right-hand side. The same pattern, the bone oscillates and increases in density in circular fashion. And it improves the surrounding hard and soft tissue. And you'll see that improvement in your clinical cases.
So you're actually somewhat correcting periodontal mobility with deficit by placing this.
And the adjacent teeth.
And the
Yes.
adjacent tooth. That's pretty cool.
Yeah.
This is fascinating. You know, I look at this picture, and what do we see? We see an implant on number 8 with some pink acrylic that was to make up for the deficit in the
Right.
tissue recession.
This patient comes to my office, and she's been seen by some specialists. They've done bone grafting on number 8, block grafting, soft tissue grafting, and then the final result, when they put the crown, they had to put that pink gingiva. And when she complained, the doctor told her, implantology is just like ceramics. When we put the final ceramic in place, sometimes you have gaps, and you have to fill them with grout. And this is how we do it. And she was told that this is a norm. And really, this is a norm sometimes when we don't capture what we lost. Now, she wanted to she wanted me to treat number 9. Now imagine, this lady is angry, ready to file lawsuits against the doctors that worked on this tooth. And she saw our infomercial, she saw me on TV, and she said, okay, you do number 9, what are you gonna do? So, typically, you just back out of this case. It has all the bells and whistles that says, stay out of this case, don't get involved. But, when you have the ultra-tooth, you know, you hear that noise? So I said, ultra-tooth. So I said, what the hell, I'm gonna do it. So I extracted, all I did is extracted tooth number 9. Now, pay attention to the soft tissue around these teeth. I call that angry tissue. Look at the soft tissue around 8 and 9. Look at the inflammation around 9. So,
Go back on this one, you see.
yeah, so look at that, and then just by extracting a tooth and putting an ultra-tooth number 9, which is the next slide, I want you to pay attention and compare the left side with the right side. What do you guys see? You can see the difference between angry and happy tissue.
Well, it looks like the tissues come down on number 9 and it's enveloping the tooth.
Exactly, that's what it's doing. Now, in this case, I offered to the patient, I said, can I start grinding and removing tooth number 8 to give it room, because it looks like everything wants to come down. And that's coming next. But you can see how things are being hard. Now, this is a week later, 9-week result when I put the final
So
crown.
at this point, you took
Impression.
the impressions at the 8 week.
Yes.
And a week later delivered the crown on number 8.
Yes. So if you go back, I want you to see the bone level between the two devices, implants. Number 8, standard implant. Number 9, look at the bone at 8 weeks, how it's hugging the ultra tube. The bone loves the ultra tube. I want you to repeat when I said ultra tube.
Ultra tube. Listen, we know that tissue is supported by bone.
Yes,
Right?
yes.
So if you're growing bone in the region, the papillary region between 8 and 9, that's why you're getting rid of the black triangle?
Exactly. Look at the papilla coming back. If you look at the comparisons, we go back and look at the pictures. In number 8 and 9, you can see that black hole. In the after, the picture on your right-hand side, you can see the papilla starting to fill in. So this is, I haven't touched number 8. All I did is treated number 9, and look what it's doing to adjacent tube.
It's actually making number 9 look healthier too.
And it's saving the doctors from a lawsuit.
Which is nowadays very costly. So let's talk about surface area. I like this picture because we see the loss of bone around a traditional implant. You know, and this reminds me of, I remember when you and I were together in a program, somebody said to you, hey Sargon, all you did is create a molly. You made a molly bolt.
Right.
What was your answer to him?
Well, I was walking around and one of these big shots of the screw implants, he comes over and says, he looks at me and he says, you're that molly bolt guy. I said, yeah, I am. He said, yeah, I use your implant on my walls to hang paintings. I said, when do you use it? When the screw falls out?
It's sort of like getting hoisted on your own guitar, so to speak, you know. But look at the pods that have expanded on the distal implant, on the Sargon implant.
Why does nature give molars 3 roots, 4 roots? Are we following nature here? Now we have greater surface area, we have Eiffel Tower effect, we have 5 roots actually on this. It's 4 pods that expand and the central screw that expands these things. So this is a clinical case that shows the difference. These 2 implants were placed at the same time. The doctor sent me the case, he said, I just had one of your implants and had a screw. So I did this case and...
Let's look at that bone that's in between here. Take a look on the left side. Look how much more bone we're seeing.
This is a histological slide of what happens inside this implant. For those wondering what happens inside, the implant osseointegrates on both surfaces. So bone goes in and fills the internal parts of this implant.
Talk to me about the pods. Now, some of us may get the impression that we're springing these things out really wide, where in fact you're increasing it maybe 1.5 millimeters to 2 millimeters.
Yeah, each side in soft bone. Now, in areas where you have teeth, the bone is stressed, and usually it's a type 2 bone, and the expansion is about 0.5 millimeter. All it goes 0.5 millimeter on each side and just basically locks into bone, makes contact with bone. The definition of osseointegration is contact with bone to metal, and we achieve that mechanically at time 0. And we maintain that, and 4 to 6 months later, biological osseointegration occurs, but the patient doesn't know the difference. The patient is using it. So only in cases where the bone is completely soft, and when you put a screw, the drill drops in and the screw just wobbles and you can't do it. In those cases, the implant expands in its full position, 1.5 millimeters on each side. And those cases we don't load immediately because there's basically spongy, there's no hollow. But what we use this implant as a bone creating machine because what it did, it microfractured and compacted the bone around it, and studies have shown us when that heals, it forms sclerotic bone and harder bone. So when we come back 3 to 4 months later, we know we have an implant that is osseointegrated versus if you had the screw that was basically wobbly.
Yeah, and the wobbly screw is when I first got involved with the ultra tube, and we had dinner and we talked about it, and I told my colleagues that I gave them a peek under the tent. I'm going out to learn about this new implant. I came out to your office and watched surgery and everything, and they said to me, what if it fails? Everybody's always worried about failure instead of focusing on 97% success rate in the
Right.
mandible, 100% in the maxilla. But I got to ask you the question, and we're going to get to that. So I know that's on everybody's mind about that. But one of the causes of failure is we get bacterial infestation, if you will,
Yes.
on some of the traditional implants.
Yes.
You came up with the concept, and you're the only implant, UltraTube is the only implant to my knowledge that is a triple seal.
The triple seal, it means that no bacteria can ever get between the implant abutment, inside the implant, or through the implant or in. What does that mean? It means that, first of all, there's no moving parts. You know all the restorations, the doctors that do screw retained restorations for retrievability. You know what that means? It means I'm scared, that things are going to get loose or break.
Because it's only a butt joint, they're just metal and metal.
Exactly. When you have two surfaces coming together and the patient biting, these parts are moving and it translates into loosening of screw or fracturing of screw. So you want to be able to go in there every few years and correct that situation. So we got around that. We got into Morris tapers, and not only we sealed it bacteriologically, now those moving parts, they collect bacteria, and you have some patients coming in and have had implants for a long time, and they complain of odor. It's because that bacteria goes into these pieces and just stays there. There's no way for them to clean it. So they have that bad breath. Now this is a triple seal. By Morris taper, first of all, the outside, the abutment, once it's tightened, it tapers and actually welds and locks to the implant. So it becomes a single unit.
So that's what we're seeing at the first seal point, the bottom left.
Opposite. I'm talking about the third seal.
Third seal on top.
Yeah, and the third seal is the outside abutment that seals to the implant. Going to the second seal, now the top of the implant, once it's expanded, the screw is expanded, we have a screw cap that goes in there and seals the top of the implant with a Morris taper. And then the first seal point is the expansion screw is designed. If you look at the microscopic picture of that in the lower left corner, when the screw is turned and the expansion occurs, the edge of the screw actually cold welds and becomes one with the other surface. So we have 3 levels of bacteriological sealing, and on top of that, what it means is that I've been able to have patients fly in from other countries and cities. They get the tooth, I give them the restoration, tell them goodbye, and I do a cemented. For the past 20 years, I've been doing cemented restoration. I do a screw retain. I'm not worried about retrievability, so I do general dentistry. Basically, by the way, all of this is in the package that the older tooth comes in. So once this is placed, it becomes just general dentistry. To restore it, you can put a cord, take an impression, and have the lab make you a regular crown, not an implant crown, which is the less costly. Now for those prosthodontists that want to register the hex, impression post, send it, and have the lab do it, we got all of that.
Or scaling, or scanning and milling.
Scanning and milling, we have all of that option. But the best option for the practice is basically to cut that driver that is titanium, it drives the implant, you cut it, it becomes an abutment. And you make a provisional right on top of it, and if you want, put a cord, take an impression. At the time of placement or later, you can scan it, and for those of you who have milling machines, you can put a final crown on it at the time of placement.
So this is a lot less parts to stop.
Absolutely, yes.
We talk about the bacteria. What you're telling me based on triple seal and what I've seen in the short time we've been doing these is that iatrogenic periodontitis or periimplantitis is not a factor anymore, other than where we've eliminated the factor we can control about make sure the bacteria is sealed from our implant. Now it's up to the patient to keep it clean.
Exactly. In April of 1991, in Dentistry Today, I published a paper, and for the first time I introduced immediate loading. I was the guy that coined the term immediate loading, copyrighted it, and later on it was taken and misinterpreted into different things. But at that time, I explained that periimplantitis really doesn't exist. We're causing the periimplantitis by putting a cylindrical screw. As soon as the load goes on, and you get a crater. When you have a crater with blood and it's dark, it's a perfect place for bacteria to grow. And then we have these joints that harbor these bacteria. So it's a perfect place to have that. And we called it periimplantitis. And when we started seeing bone loss, we blame it on the patient. You're not brushing. You're not flossing. It's not their fault. The device that you put in there is creating that. So now we're taking away that. We don't have any loose parts. We don't have any bone loss around it. And the patient comes back years happy and they don't have any problems. So I don't know what else can you give the patient if you have to.
That's terrific. Now, I had started to talk about this before. The naysayers are going to say, what if it fails? Yeah. And we both know when an implant fails, you pretty much can just pull it out.
I've done over 15,000 over the past 27 years. And my failures, yeah, it does if you overload it. Sometimes, with time, the design of the prosthesis is not correct and stuff. You see this bone loss. If I catch it early, we have techniques, I have techniques, we graft it and I save it. But if I don't get to it on time, if it fails, basically remove it with your finger. But some people are still concerned, saying that if this, for example, you want to remove it, and I have removed 5 cases, and 2 of them were in the university in a class, because the patient wanted the implants more palatally and for his cosmetic aesthetic. So they called me and I showed them. The mechanism is reversible. First of all, when you place it and expand it, it's fully reversible, so you can unscrew it and it'll collapse at the time of placement. So before you expand it, you want to make sure your positioning and everything is correct, because once you expand it, it's considered osseointegrated. Once you collapse it and you re-expand it in a different position, then you compact it the entire surrounding bone, just like a screw does, then it becomes non-immediate load situation. But if you have a screw that has already integrated partial bone loss and you want to remove it, the same thing can be done. What we do, we loosen this screw inside and we tap on it. As the screw goes up, the expansion point, just like a plunger, it pushes out that spongy bone between the legs. So once that bone is out, it takes about a minute. You just tap on the screw and it just goes down. Now the legs are not supported anymore. Then you take a trephine, cylindrical trephine, just like you do with regular screws, the same diameter as the top of the implant, not the bottom of the implant. And you send the trephine in and it gets to the legs. Because the legs are no longer supported, it just collapses, and you can take it, as you can see in this picture. So this is one of those rare occasions that...
Yeah, but we got to address the elephant.
Sure.
For sure. Yeah. All right, I want you to take, we can't all be in your surgery, but let's go through a surgical procedure right now where you're going to remove the lateral.
So think about your practices and how this affects your practice. How many extractions do you do? How many times a patient comes in and has a bad tooth, and the first thing you do is like, oh, you have to take it out. You take out the tooth and then you start thinking what we're going to do about it. We're going to do a bridge, because right now I can basically prep this, bill it, get the money, and you say that's the way we go. Or we do an implant, refer it, basically lose track of the patient sometimes, the patient doesn't come back. At that moment, when you tell the patient, I'm going to give you a brand new tooth, this is the best time to sell that treatment to make the patient happy and turn a $200 treatment into a minimum $2,500 treatment. Now you can charge $2,500 depending on your area. I know some people charge $6,000, $7,000 for this procedure.